We're going to start the session. I'm going to ask Dr. Michael Belin to give us an update on progression of keratoconus.
Thank you. Being the first speaker is kind of strange. There are two theories to why someone asks you to talk first. Either they think your name will draw people in, or they want to get you off the podium before too many people arrive. And if you look around the room, I think it's a toss-up. So imaging keratoconus, are we progressing? These are my disclosures. I'm a CMO for CXL Ophthalmic and a consultant for Oculus. So unfortunately, people use Kmax, and have been using Kmax for a number of years. And most people realize it's really a terrible limited parameter. It measures only one single point, and also it only occurs, the only thing changes after you've lost vision. But how did Kmax become the holy grail of progression? It really dates back to one of the original articles in Cross-Linking back in 2003. And this is what they looked at in that original study, both preoperative and postoperative exams. They looked at BSC CVA, corneal topography, but only the anterior surface, Goldman tonometry, central endothelial cell counts, photography, slit lamp and fundus, and actually they only did pachymetry in the last 8 patients. And what did they find? Well, in a retrospective analysis, the only value that actually reached statistical significance was the K value. So how did Kmax become the holy grail of cross-linking progression? It was a 2003 retrospective analysis from a small pilot study that looked at a very limited number of patients. And again, Kmax was the only parameter that actually reached statistical significance. Interestingly, if you look at the CLEK study, and again, the CLEK study is the largest NIH-funded study in the natural progression of keratoconus, nowhere in any of the CLEK papers is Kmax mentioned. And this is the problem with Kmax. For those of you who are car enthusiasts, this is called an idiot light. It lets you know when damage has been done. It's too late. And that's what Kmax is. Again, to have an abnormality in Kmax, you have to have lost some vision. And to determine progression based on Kmax, it means you have to lose even more vision. What we really need is a way to monitor disease like we do now. We need to know when changes occur before damage is done. So when should we intervene? Well, the holy grail is not Kmax. That parameter should allow the earliest possible identification of disease in the subclinical stage, which is true disease, with the goal of preventing or improving vision, not treating vision after it's already been lost. And that's nothing new. If you think about most of medicine, can you imagine if your medical doctor said, I'm only going to treat your high blood pressure after the first stroke, you would walk out of the office. You don't treat diabetes after the first episode of ketoacidosis. You don't treat high cholesterol after the first MI. Why are we currently treating keratoconus only after the patient loses vision? So the reliance on Kmax, both as an efficacy parameter and as determination of progression, has resulted in irreversible loss of vision, has delayed intervention, and really prevented us from doing what we should be doing, which is the prevention of sequelae, not treating sequelae after it already occurs. And for those of you familiar with the Belin and brochure display, here's an example of, again, a true keratoconic, a true ectatic disease, and if my pointer works, you will see here a completely normal anterior surface. You notice every single parameter is abnormal except for the anterior surface. This is true disease. Patient has normal vision. This is when you want to stabilize the disease, not wait until they've lost vision. But if you look at every single prior progression parameter that's in the literature, except for pachymetry here, every single one is an anterior surface parameter. Again, meaning that you have to have lost vision and then lost even more before the progression is determined. So a couple of years ago, we introduced a new classification system, really because of the global consensus recognized that amsulcrumac was really not appropriate with new interventions like cross-linking. And the ABCD classification graded each anatomical layer. A was the anterior radius of curvature from a 3 millimeter zone centered on the thinnest point. Again, amsulcrumac was just an apical reading. This is centered at the cone. B, or back, was posterior radius of curvature, again from a 3 millimeter zone at the thinnest point. C was minimal corneal thickness, not an apical reading, but the minimal corneal thickness. And D was distance visual acuity. But the real goal of this wasn't just the classification, it was to determine a method and to document true progressive disease. And this is the second iteration of the progression display. It allows you to display up to 8 exams over time and tells you when you have statistically significant change on each anatomical layer. A is the anterior surface, B, back posterior, C is minimal corneal thickness, and D is operator-entered distance visual acuity, and lets you compare it against 2 different populations. The green flags represent a normal population noise level, and the red a keratoconic, and it lets you know when you have 80 or 95% confidence interval of change. So let's look at an example. Here is a 15-year-old with advanced keratoconus and 7-year follow-up, and you will notice that there's highly significant change on every parameter, the anterior surface, the posterior surface, and corneal thickness. The user here did not enter distance visual acuity, and if you look at Kmax, you'll see a progressive increase in Kmax. But what's the clinical utility of this? This is the example. Here's a 15-year-old, very early keratoconus and a 13-month follow-up. Notice Kmax, no significant change at all. Notice the anterior surface, no significant change, but notice what's going on in the back of the cornea. Progressive posterior ectasia. This is when you want to intervene. This, you preserve vision in this 15-year-old. You're not waiting until the anterior surface gets distorted and he loses or she loses vision. Here is a 16-year-old, again, progressive subclinical disease. Notice it's less than a diopter change in Kmax, but notice the anterior surface, significant change, but again, marked change well past the 95% confidence interval on the posterior surface, and again, continued corneal thinning here. So again, documented statistically significant change in spite of the fact that Kmax doesn't reach what most people use as far as significance. Here's an 18-year-old, again, notice the Kmax, stable, actually it's even looking lower, and you'll notice the right eye at a 95% confidence interval on the posterior surface, and the left eye, marked change in the posterior surface. Again, we're documenting highly statistically significant progressive disease in spite of good visual acuity and a stable Kmax. Here's a progressively advanced keratoconus. Notice the bad D is greater than 7. This is not early disease, but notice again, the anterior surface has no change. Kmax is stable, but look what's going on in the back and corneal thinning. Progressive disease, again, an indicator to treat. So how do we diagnose progression of keratoconus? We recognize that there's a dissociation of clinical progression with changes in Kmax. We now have a tomographic-based classification system and also a tomographic-based progression display that will document when you have statistically significant change. Thank you.